Assalamu alaikum wa rahmatullahi wa barakatuhu. Bismillahirrahmanirrahim. Dear students of fourth year MBBS, today we will discuss primary narrow angle glaucoma. Learning objectives of this lecture are that at the end of the lecture you must know what is primary narrow angle glaucoma, what are its types, what is pathogenesis, and how can you diagnose and manage a case of primary narrow angle glaucoma. So primary angle closure glaucoma is a condition in which elevation of intraocular pressure occurs as a result of obstruction of aqueous outflow by partial or complete closure of the angle by the peripheral iris. Usually one eye is affected and patient presented as a narrow angle glaucoma. But this condition is usually bilateral. If one eye is affected, other eye is prone to have narrow angle glaucoma in the future. Here you can appreciate the diagrammatic presentation of angle of interior chamber. On left hand picture, you can appreciate a wide open angle of 45 degree, and it is called the grade 4 angle by the Schaeffer and Becker classification. If you visualize this angle by the help of gonioscope, you can visualize the ciliary body easily. And grade 3 angle, which is not shown in this picture, is from 25 to 35 degree, and both grade 4 and grade 3 angles are non-occludable angles. In grade 3 angle, you can visualize with the help of gonioscope the scleral spur. And grade 2 and grade 1 angle is occludable angles. In grade 2, with the help of gonioscope, you can only visualize trabeculum and the end of the Descemet's membrane. And in the grade 1 angle, with the help of gonioscope, you can only visualize the Shelby line. And the Shelby line is the end of the Descemet's membrane. And the right lower picture, that is the grade 0 angle, total iridocorneal contact is there, and nothing is visible by the gonioscope. In this picture, angle of the interior chamber is shown, which is narrower than normal, so that aqueous cannot flow freely through the pupil and it accumulates into the posterior chamber. Normally, the aqueous passes from the posterior chamber into the interior chamber through the pupil, then through the trabecular meshwork into the canal of Schlemm, and then epicyclic vessels. Here, if the obstruction is there at the level of pupil, so the aqueous accumulates in the posterior chamber and pushes the iris forward, occluding the trabecular meshwork, so causing the rise in the intraocular pressure. What are the risk factors for closed angle glaucoma? Age is one of the factors. More is the age, more are the chances of closed angle glaucoma. But normally, average age of a patient presenting by a closed angle glaucoma is about 60 years of age. And prevalence over the 40 years of age is 1 into 1000 of a normal population. And this type of glaucoma is the second most common glaucoma after the primary open angle glaucoma. Primary open angle glaucoma is the commonest. And family history of closed angle glaucoma is another risk factor. If you suspect Suspecting a patient of having narrow angle glaucoma, if family history is positive, he is more prone to have the narrow angle glaucoma. And hypermetropia is the other cause. In hypermetropia, the axial length is narrow. Normally, the eye is small. So iris lens diaphragm is forwardly placed. Lens pushes the iris forward, which causes the eye more prone to have the narrow angle. And if lens is intumescent, means it imbibes the water and becomes bigger in size, it pushes the iris forward, so another risk factor. And if I have injury or surgery previously, it may have caused the injury at the level of angle of the anterior chamber, causing post peripheral anterior synechia, so it contribute into the causing the closed angle glaucoma. Anatomical predisposing factors for a narrow angle glaucoma are relatively interior location of the iris lens diaphragm. As in case of hypermetropia, the iris lens diaphragm is forwardly placed. Shallow anterior chamber and narrow entrance to the chamber angle. And other is the lens size. More is the size of the lens, as in when it imbibes water in diabetic cataract, it becomes bigger in size. So it pushes the iris forward, can contribute into to have a narrow angle glaucoma. Corneal diameter is another factor. Less is the diameter, more are the chances to have the narrow angle. And axial length, interior posterior length is small, it means the eye is small. In that case, it also iris lens diaphragm is forwardly placed and it can cause or predispose to have a narrow angle glaucoma. The pathogenesis of the acute narrow angle glaucoma, it is the pupillary block. Iris lens apposition causes resistance to the aqueous outflow from the posterior chamber into the anterior chamber. And this aqueous accumulates into the posterior chamber, pushing the iris forward. So interior bowing of the peripheral iris is there, that is called the iris bumby. Two theories are put forward for this: dilator muscle theory and sphincter muscle theory. Sphincter muscle theory suggests that the sphincter of the pupil is the prime culprit. Pupillary blocking force of the sphincter is the greatest when the diameter of pupil is approximately 4 millimeter. So normally in old age, as the narrow angle glaucoma is more common as the age grows. So normally in old age, pupil size is about 2 to 3 millimeter. But if the individual having pupil size of 2 to 3 millimeter, if is doing any work in the dim light, say watching TV or reading or swimming, or certain professionals like X-ray technicians or radiologists, they work in dim light, then the pupil becomes about dilated 4 millimeter. And in this case, the apposition of iris lens apposition is increased. So the resistance to aqueous outflow is increased and resulting into the rise in the intraocular pressure. The dilator muscle theory, in dilator muscle increases the amount of apposition between the iris and interior located lens and increase the degree of physiological pupil block. In this picture, you can see, you can appreciate the sequence of happening in the acute narrow angle glaucoma. In the first picture, there you can appreciate the firm apposition between iris and lens causing the resistance to the aqueous outflow. In the second picture, you can appreciate the aqueous is accumulating in the posterior chamber, which pushes the iris forward, so occluding the angle chamber. And mm, it becomes, a patient goes into a vicious cycle, and ultimately iridocorneal contact is there, so suddenly causing the abrupt rise of intraocular pressure. So coming back to the pathogenesis of the narrow angle glaucoma, it is the drainage angle of trabecular meshwork becomes blocked by the iris due to shallow anterior chamber. So once ultimately the iridocorneal contact, as you can appreciate in the right hand picture, there is a iridocorneal contact totally blocking the angle chamber. So there is no drainage of aqueous, so it causes sudden rise of intraocular pressure. Now come to the classification of the narrow angle glaucoma, or the stages of narrow angle glaucoma. It can be divided into 5 stages. The latent, where the patient has no symptoms, it is a dormant. Intermittent or subacute stage. Acute, congestive or post-congestive stage. Chronic, and last stage is the absolute stage, where the eyes have no vision. So latent glaucoma, or the glaucoma suspect, are those patients who are symptom free. But when you examine the patient, you can appreciate that IOP is normal, but the interior chamber depth is less than normal. And if you visualize the angle of the interior chamber with the gonioscope, you come to know that the angle is of grade 1 or 2. If you have come across a patient like this, and there are other risk factors are present, then you go for laser peripheral orotomy, so that the risk of having acute congestive glaucoma in the future may be averted. Next comes the intermittent stage. In the intermittent stage, it is the narrow angle which closes for a short period and then reopens spontaneously. So for a short period, when the angle is closes, intraocular pressure rises and giving rise the symptoms to the patient. And what is the mechanism of rise of intraocular pressure? In these patients, usually the physiological midriff is there. Patient is working in a dim light, pupil dilate, and apposition of the iris and lens is increased. So resistance to the aqueous outflow is increased. So relatively pupillary block is there. So iris pushes forward and mechanically blocking the angle. So it gave rise to the temporary rise of intraocular pressure. But the patient, when the patient comes out from the dark room and favorable conditions are there and pupil is constricted, intraocular pressure fall back and the patient feels normal. So what are the clinical features of this subacute stage? Patient complains of having transient blurring of vision. It is due to the corneal edema, and also patient complains of halos around lights, and these are also due to corneal edema. If you pass a slit in front of the pupil, these halos are not breakable, but the halos due to cataract are breakable. Patient also complains of having headache, eye ache, and then this attack is aborted when the physiological meiosis occurs. Patient comes out from the dim light or dark area into light, pupil constricts, angle is open, intraocular pressure falls back as the drainage from the interior chamber is increased. So intraocular pressure is normal in between attacks in the subacute stage. and gonioscopy show the narrow angle. By the provocative test, we come to know that whether this patient is prone to have subacute intermittent attack later on leading to acute narrow angle glaucoma or acute congestive glaucoma. We can do the test, water drinking test, dark room test, pharmacological test. Water drinking test. In this test, we ask the patient to drink 1 liter of water and take the intraocular pressure after 1 hour. And intraocular pressure rises 8 millimeter or more. In case of dark room test, we ask the patient to sit in a dark room in awake, and after 1 hour we take the intraocular pressure and rise is usually 8 millimeter of mercury or more. And pharmacological test is we put weak mydriatics into the eye to dilate the pupil, and after some time we take the intraocular pressure. It has usually rise of 8 millimeter of mercury or more. So in a patient where provocative tests are positive and other relatively risk factors are there, so you must treat this patient initially with 2% pilocarpine, and then you can plan for laser peripheral iridotomy. The third stage is acute congestive angle closure glaucoma or congestive phase. The pathogenesis of this acute congestive glaucoma is ultimately the iridocorneal contact is there due to accumulation of aqueous humor into the posterior chamber, which pushes the iris forward, ultimately causing the total blockage. So it causes ischemia of the iris, and a release of prostaglandin is there. And due to the release of prostaglandin, it causes severe inflammation. And of course, due to the sudden rise of intraocular pressure, stretching of the corneal nerve ending is there, and it causes pain. Now come to the symptoms and signs of the acute congestive glaucoma. In this case, patient complains of having systemic complaints and the local. In the systemic complaints, severe headache and eye ache is there along with nausea and vomiting. As the patient present with nausea, vomiting, and headache, sometimes it landed into the medical department instead of the eye department. Patient also complains of severe blurring of vision, severe redness, halos around lights. And when you examine the patient, you find that there may be lid swelling, chemosis, eyes is severely red due to ciliary and conjunctival congestion, eye is teary, having lacrimation, corneal edema is there, and you find the angle is closed, interior chamber is shallow, aqueous muddy, as due to congestion of the vessels, iris vessels, the fluid comes out and the cells comes out into the interior chamber, causing the aqueous muddy. Pupil is mid-dilated, fixed, non-reacting, and loss is texture. Glaucoma flecken may be there. It is a condition where you can find the gray-white opacity on the lens. It is due to the atrophy of the newly formed lens fiber under the capsule. And lately, iris atrophy may be there. In this picture, you can appreciate circumcorneal congestion, corneal edema, pupil is mid-dilated, posterior synechias are there, and lens texture is not normal. It's having glaucoma fleckens, white opacities. It's a case of previously having acute congestive glaucoma. In this picture, a patient having acute narrow angle glaucoma, you can appreciate iris bombi. Iris is bulging forward, so causing the occlusion of the interior chamber angle. Posterior synechias are there, lens opacity is there, and on left hand picture, it's the OCT of a case of acute congestive glaucoma. Here you can appreciate total iridocorneal contact obstructing the angle chamber and posterior synechia. So in case of acute congestive glaucoma, though its gonioscopy is not possible as the cornea is hazy, but if you clear the cornea with the 50% glycerine to some extent, you can appreciate a little bit angle of the interior chamber. There will you see the complete peripheral iridocorneal contact in the Schaeffer grading grade 0. No angle structure is visible. And normally ophthalmoscopy is not possible, but when you have made the cornea relatively clear with the glycerine, you can see the fundus, and possibly fundus shows disc edema, hyperemia, and the hemorrhages. So what is the treatment of acute congestive glaucoma? It is a sight-threatening emergency in ophthalmology. So you have to institute the treatment as early as possible. And aim of treatment is to control the acute attack, to prevent the future attack, and to prevent future attack in fellow eye. And what is the treatment? You can divide the treatment into two portions, medical treatment and surgical treatment. And medical treatment is further divided into systemic therapy and topical therapy. In the systemic therapy, you give the acetazolamide 50 milligram stat IV or orally, and then followed by 250 milligram 6 hourly. You can also use hyperosmotic agents, mannitol 20%, 1 to 2 gram per kg body weight intravenously, and you infuse 60 to 100 drops per minute about in next hour or two. You can give the glycerol 2 to 3 ml of 50% solution per kg body weight. And for topical therapy, you give pilocarpine 2%, initially very frequently and then 6 hourly. But if you have not lowered the intraocular pressure with the help of systemic therapy, pilocarpine will not work unless you have lowered the intraocular pressure to a certain extent. So the pilocarpine pulls the iris inward and clear the chamber angle. So the aqueous outflow started and it aborts the acute congestive glaucoma. Beta blocker with combination of carbonic anhydrase 2% can be used to lower the intraocular pressure, and topical steroids are option to control the inflammation. For surgical treatment, once the patient is stable, you have lowered the intraocular pressure with the help of medical treatment, patient is comfortable, then you plan for laser peripheral iridotomy or surgical peripheral iridotomy, depending upon the facilities available. So you make a hole in the peripheral iris, and by this method you bypass the pupillary pathway, and the aqueous directly flow from the posterior chamber into the interior chamber through this hole. So this by this method, as you bypass the pupillary pathway, so the chances of attack in the future is aborted. So you always, if the other patient is having risk factors, and usually the other eye may be involved in the future, so you do the peripheral laser iridotomy to avoid any chance of having acute congestive glaucoma in the future. Trabeculectomy is the other answer, and we do the trabeculectomy if we do the gonioscopy and find that 50% or more angle chamber is closed, having interior synechia, then the iridotomy will not work. Then you have to do the trabeculectomy. And other stage is post-congestive angle closure glaucoma. It may be seen in following three clinical conditions: post-surgical, spontaneous angle reopening, and ciliary body shutdown. And clinical features of post-congestive angle closure glaucoma are intraocular pressure may be normal, subnormal, or elevated. Folds in the descemet membranes may be present. Pigment granules on the corneal endothelium. Stromal atrophy. Fixed and semi-dilated pupil. Aqueous flare and cells. Glaucoma flecken. These are the small white interior subcapsular opacities due to atrophy of the newly formed lens fiber in the pupillary zone. In this picture, you can appreciate a post-congestive angle pupil, and you can appreciate the posterior synechia. Iris is atrophic and glaucoma fleckens are present. In left-hand picture of post-congestive angle closure glaucoma, you can appreciate the iris atrophy. Pupil is semicircular, dilated, irregular. And on the right-hand picture, you can appreciate the optic trophy. Due to long-standing acute congestive glaucoma, it causes the ischemic optic neuropathy leading to optic trophy. In this picture, you can see the chalky white disc with filled cup. And other stage, chroning angle closure. There may be creeping angle closure, frequent attacks of intermittent angle closure. It resembles primary open angle glaucoma, except that gonioscopy shows peripheral anterior synechia, but the intraocular pressure remains continuously elevated. You will tackle the chronic angle closure glaucoma with the medical treatment, as we have mentioned in previous lecture and in this lecture previously. Surgical treatment is the peripheral iridotomy or iridectomy, but if it fails, you can proceed to the trabeculectomy. And last stage is the absolute glaucoma. It's the end stage when the acute congestive glaucoma is not tackled properly and the patient have ultimately the ischemic optic neuropathy and patient is blind. So the patient is painful or painless hard blind eye due to post-acute congestive glaucoma. But other secondary glaucomas may lead to ultimately to absolute glaucoma if not treated properly. So the clinical features of absolute glaucoma are: there is no perception of light, eye is blind, cornea may be clear or having edema, eye is usually painful, ciliary congestion is there, interior chamber is shallow, and optic atrophy is there. So what is the treatment of absolute glaucoma? And why we treat the absolute glaucoma when there is no vision? So the aim of the treatment is to keep the eye comfortable. We use the anti-glaucoma drugs, we give cycloplegic drugs, we can use the steroids to curtail the inflammation. We can give retrobulbar alcohol injections so that denervation of the nerve supply, causing denervation of nerve supply, so tackling the pain of the patient. We can use the cyclocryotherapy. By this method, we destruct the ciliary body and secretion of the intraocular aqueous is decreased, so decrease of the intraocular pressure. And similarly, we can destroy the ciliary body with diode laser ablation. Filtration operation is another answer. But if all these procedures fail, the enucleation is the answer. This was all about acute narrow angle glaucoma, ladies and gentlemen. Now I am giving you the assignment. In the previous lecture, we have discussed primary open angle glaucoma. So, considering the previous lecture and this lecture, you just take assignment where you mention differences in primary open angle glaucoma and acute congestive glaucoma in terms of symptoms, signs, complications, pathogenesis, and the difference in the diagnosis of the two diseases and difference in treatment. You send your assignment on the given WhatsApp number and email address up to 6 p.m. on the same day, and your presence will be marked according to your response. Thank you very much, ladies and gentlemen, for patient listening. Thank you very much.